Any new colleagues in the room that need introductions today? Or has everyone been before? Hello, Sarah. Hi. Would you want to introduce yourself to the meeting?
Hi there. Hi, everybody. My name's Sarah Harvey. I've just recently started with the ICB in the role of Head of Primary and Community Care Strategic Planning.
Well, you're welcome to join us, Sarah.
Thank you
very much. Good to have you here. Other than that, I'll assume that everyone knows everyone else and won't go round for introductions, if that's okay, just to save us time. But hopefully colleagues have got copies of the agenda and the papers. There's a couple of additional emails as well, I think, that would be useful for people to have had, and I'll draw attention to those as we go through the meeting. Should also point out that whilst this isn't a public meeting in public, as it were, we will be recording this meeting, and this meeting will be on YouTube. So we should bear that in mind as we go through both for the part one of this meeting. And we've got a separate Teams appointment in the diary for the part two. And when we get to that point, we'll close this half of the agenda and go into that other meeting with it, hopefully with a break as well. So I hope everybody is comfortable with that. And shall we start with apologies from absence? Sarah, I think you've sent a list. Patricia Dorsey, I think Chris is here for Patricia. Michael Dennis, Sue Merton and Hilary Byrne. Is there any others, Sarah, that you need to let us know about?
No, but I can't see from my list that Chris is online at the moment.
Okay.
So we don't have him currently.
Right. Sadie.
Yeah, I also noted that Stephen wasn't here, so I just wanted to check with James if he was formally deputising for Stephen, because then we will be quorate if he is.
I can do, that's fine. Okay.
Thank you.
Great, good point, Sadie. Well spotted, and thank you, James, for doing that. That's great. Okay, so we've got in the pack a set of declarations of interest. So does anybody want to make any other declarations in relation to this specific meeting? James.
Yes, thank you very much. I'll turn my camera off. As you can see, I'm on the side. For some reason, my computer is putting me on the side. So I'll turn that off now. But Chair, I am a patient at the High Street Surgery in Lowestoft, which is actually under agenda item 9. So just would like that recorded. Thank you.
Noted. Thank you, James. Anything else? Other than that, we'll take that as read. Do we just have someone else being admitted?
Yes, the LMC.
Great. Thank you, Sarah, and welcome to the meeting. All right, so we'll go back to our agenda and just review the minutes and the action logs from our November meeting. So if I take matters of, as it were, accuracy first, so I just go through the page by page through the minutes just to take anything people want to pick up. Hein.
Thanks, James. James Grange, I think, should be reflected as a voting member because he was deputising for the Director of Finance last time, so that can be reflected. Thank you.
Thank you, will do. Thanks very much. Anything else on page 1? On page 2 of 10, 3 of 10, and 4 of 10, 5 of 10, 6 of 10, 7 of 10, 8 of 10, 9 of 10, and finally 10 of 10. Okay, I think that's great. So we'll record those as an accurate minute of the meeting, if that's okay. And then in relation to the action log, we've got 4 items on the action log. I think some of them are due in 23, so they're not, as it were, due for review now, but we've got 2 that are due for today. So the first has FT as an owner, the enhanced access. Any update on that, Sarah or Sadie? Presume.
Fiona's on the
Oh.
call, James.
Fiona, sorry.
That's right. Yes, this is now being taken forward by our contracts team within the ICB, who initially negotiated the contract for blood collections with the NNN. So hopefully we can reach a conclusion on this. Although I think there are some challenges around workforce and the capacity for the service to provide sachet collections. So discussions are ongoing around this.
Great, thank you. That's very helpful. And the next item was just the minutes themselves, which we've dealt with. So are there any issues to raise, Sadie, in relation to the forward planner for the meeting? It's just for noting, isn't it? But anything you want to raise with us about that?
I think we had a couple of items which we've not got on today's agenda. So one of them is the review of the terms of reference, and that's because that piece of work is underway, but there's a new timeline attached to that to fit into the wider review of ICB committees. That will come in the new year. And the second is the report on enhanced access, simply because there was no real new information, so it would have been a report for the sake of it. So we will bring that in due course, as and when we can provide a fuller update. Okay, thank you. If there's no other comments, then I'll move us on in terms of our agenda. So the next item is the Director of Primary Care update, which is with Mark Burgess. So we've got your report, Mark. Over to you.
Thank you, James. And as always, I'll take the report as read, but there are a couple of items or a couple of areas I would like to just talk a little bit about, if I may, please. So good afternoon, everyone. So the first thing to say that in the report, it does highlight the real progress being made around the booster programme and the flu uptake across Norfolk and Waveney. I think real progress is being made, so I'd just like to acknowledge that. And the report states 68% last month. Actually, that's gone up to 70% for the booster programme as an example, which I think puts us best in region and 6th or 7th nationally. I think somewhere along those lines. So I think real testament to many people actually in the team who have done some fantastic work to support the rollout of the booster programme, which we hope will help us over the coming months. But two areas I'd really like to just flag and explore a bit further with the committee are firstly to note the increasing appointment activity that we're seeing across primary care and general practice at the moment. I won't quote the stats in the report, but there are some quite eye-opening stats around the additional activity that's being performed. A lot of those, yes, absolutely relate to vaccinations as well, but actually I think it does give a real example of just how much activity is being performed in general practice at the moment, and links to the next item on the report. The only thing I'd like to add that isn't included in the report is some will have seen that Health Watch have very helpfully provided a report to us around feedback from patients and some of the work that's been happening there and the patients' views. It was positive, some very real positives to note there as well around positive experience by many of our patients, but it also highlights where there are things and areas that we could do better. So we will work with general practice. One of those areas around that patients were highlighting were around delayed time answering telephones. So we recognise that and we'll be working with practices and to support practices recognising those very real pressures at the moment. So and the other one, the increasing activity stat in the report that is a concern to us given those pressures, between September and October we did see an increase in the number of missed appointments and did not attend, which is now over 30,000, which when these appointments are so precious, that is a concern for us. So we're going to work with the comms and engagement team to see if we can get some messages out to support practices and support patients, actually, to make sure that we can make every appointment that is available there and is utilised. Which all leads to the other part that I'd just like to highlight is that more and more we're picking up examples of how primary care and general practice resilience really is being tested at the moment. That's with a background of growing demand, increasing workload pressures, and of course the workforce shortages that we've talked about at this committee here before. We're also getting reports, unfortunately, around increases in abusive behaviour. I know some of that is linked to frustrations that some of our patients feel, but I think we'd all agree that abusive behaviour absolutely should not be tolerated. So we will be, as an ICB team, looking again at what messages how can we work with our comms and engagement team to support patients, support our practices, to make sure that we really do help where we can in a number of areas. In support of primary care resilience and how it is being tested at the moment, one of the things that we are looking at as a part of our urgent and emergency care demands that we have across the system, we have been allocated some funding this year to support winter pressures. It's very focused around supporting discharge, but we have taken steps. That process is ongoing now around sign off of that, and it will go to the Health and Wellbeing Board for sign off. But I think, with primary care playing such an integral role, important part of our urgent emergency care system, I think it's upwards of 80% of our urgent care activity is dealt with, as I know I've quoted before, in primary care. So it's an area that we're looking at. What can we do more as an ICB and as a system to support primary care, to support the overall system resilience? So that is a real and growing concern of mine, and I know of many of the people on this call. So in future months, we plan to bring back more updates around some of the work that we hope that we can do to support general practice, James. But thank you very much indeed for listening, and happy to answer any questions.
Thank you, Mark. Thanks for the introduction and for the report. Perhaps before I open it out, perhaps on the winter pressures and the, as it were, funded schemes, once those decisions are made, it would be helpful, I think, for the committee just to have sight of those so that we can see what's relevant to social care and primary care and community care and acute care and so on. Okay, any comments or questions, colleagues? Andrew.
Yeah, thank you. Hi, Mark. Hugely impressed you've read our Healthwatch report already. It was only published last night, I think. So well done on that. Just a few things to emphasise, which we've said numerous times before, but it's the communication is often the nub of all this, and explaining to our patients the meaning of all the various new professions and what they do, and also what triage is, and people don't understand that. I went along to quite a number of those sessions where we gathered that data information, and it's quite remarkable talking to people how diverse their opinions are, really, in that you can get one person who says that they wish everything should be virtual and that they can't understand why the NHS hasn't caught up yet, and the next person who comes along says that they hate the whole idea of virtual access and want everything to be face to face, and that's the dilemma that we're all battling with, I guess. Yeah, morale, I think, is very difficult. I did an appraisal with a GP yesterday who was using words like despondent and despairing, and again, we've brought that out before. And then the other question I have, and this was somebody asked me, I know NHS England have recommended perhaps considering respiratory hubs as a short-term measure over the winter months, both to do with, well, not so much COVID now, but all the usual viral infections, but also particularly the strep A problems. Have we had any thoughts on respiratory hubs locally?
Yes, absolutely, we have, and in fact, in many, it's a bit of a must-do. So, firstly, Andrew, thank you, and on your first comment, we absolutely recognise that difference in opinion of many people as well. And I think there's also something about expectation. I think people's expectation has changed over the years. I was speaking to one GP colleague very recently who, on one of their reports back, Friends and Family, were criticised, but it was a Norwich practice. And there was a comment made around it would be nice to know, they expected to be informed when road closures around the practice were happening, and when Norwich home matches were on, because it was taking them longer to get to the surgery. And I'm thinking, well, should they be doing that, or should, so I think people's expectations are changing as well. On the respiratory hubs, absolutely, this is something that's very topical at the moment. In fact, Sadie and I were talking about it just this morning. We are looking at that and looking to roll out some of these quite quickly, so that we've got a team now looking at that. I think by the next meeting we'll be able to update on exactly what is happening around that. But Sadie, I've probably missed something important. Is there anything you'd like to add on the respiratory hubs work? But it is definitely happening, Andrew.
No, I think you've covered it. It's a work in progress, Andrew, following the letter that came out last week.
Thank you, Andrew, Mark and Sadie. Moving on to James.
Yes, thank you very much indeed. Just very much wanted to highlight and support your views on bullying. I think that is absolutely outrageous. It must not be tolerated. And I'd be very interested to know how we can help those practices and what we are doing. I think once again, leading on from Andrew's comment about communication, I think 99.6% of patients would be outraged, and I just want my voice to be supportive of any approach that the committee can do for that. Thank you, Chair.
Thank you, James. That's appreciated. Mel.
Hi, everyone. I just wanted to reiterate Andrew's comments, as hopefully you all received the comments that we fed back last week around the resilience of general practice and the risk that is, the causes and the risk, with some key causes being identified in that email that was shared with you all. But I just wanted to really reiterate Andrew's comments about the morale of GPs and their practice staff, and it's difficult to comprehend that we're saying it's getting worse and worse and worse, and the despondency, the frustration, the level of despair, I think, is the word actually within general practice, and I would say that's reflected in all staff groups. It's not just GPs, and I think it's really important that the identified risks and the identified causes of that just stay on this agenda until there is some tangible solution to them, because we are going to see a significant migration of staff very shortly.
Yeah, thank you, Mel. I mean, I'm sure people are nodding and everyone will agree. It's absolutely the core of our agenda in a way, isn't it? The resilience issue and the quality issue. So completely concur with that. We'll stay on our agenda. Can I go to James Foster? You're muted, James, still. I know that feeling.
First time in 2 weeks, it comes as a shocker. I thought I was over it, but here I am. So 2 quick points, if I may. One, the most damaging form of bullying is the psychological bullying. So I would like everybody to stretch their definition of difficulty and not to feel about it just shouting and abuse. It's well-spoken, articulate, white-collar entitlement in which they belittle reception staff and others because of their expectations. That has more damage on my staff than somebody merely shouting. So I just want to make sure that everybody widens their perspective of who is committing And some of those people don't recognise that they are actually bullying staff. They feel they're just asking for their due rights, and that becomes very difficult, because I had member staff leave early last week, and a couple of times because of that behaviour. Secondly, winter pressures. It's all very well, but we've got 1/7 of the amount of direct winter pressure support this winter than we had last winter going into primary care. I realise discharge is a thing, and we're kind of doing our best, but there is a loss of direct support in primary care that will unfortunately probably affect the system as it goes through. But I recognise limited pot and all of that stuff.
Yeah, thank you, James. Mark, did you want to come back on those points then?
Yes, thank you. Firstly, thanks to James, well, both Jameses, about the comments about supporting our stance and position around bullying, and really good point, James, who's just spoken around the impact, and it's not necessarily just the shouting and hurling abuse that's very vocal that we hear. James, in terms of the funding, this, just to reassure you, this is something that we're escalating up the line to NHS England and beyond around. We're talking today about the very real concerns we all have and share, as Mel and others have highlighted, around the resilience of general practice and primary care more broadly. We don't yet. We have asked the question, are we expecting any additional winter access funding this year? At the moment, the answer is no, we are not. But we continue to highlight the risks, the concerns, and we're looking at what we can do locally to support. But absolutely acknowledge the risk you highlight there. Sadly, we don't have an infinite pot.
No, okay, thank you.
Thank you, Mark, for picking the point up. Bill.
Thank you, Chairman. It was just a quick question, really, around the point that's just been mentioned about the winter precious money, and I just want to reiterate: is that a decision that's been taken by the local system, or is that a decision taken by region, or is that a decision taken nationally? Just so we're clear.
Yeah, thank you. So there's very specific technical guidance around what the funding can and cannot be used for, Bill. So that's with all of the schemes that have been proposed, we've had to go through each of the schemes that we've come up with locally to see, do they meet the technical guidance? And there is a very heavy bias towards to supporting discharge, as you might expect. But we're using that. There are many things that can be done to support discharge from hospital and from community hospitals as well. So we're trying to be flexible, but I think it's been nationally set around how that money can be utilised, Bill.
Thank you, Mark. And Sadie.
Thank you. It's just to follow on from Bill's question. Last year, the National NHS England team awarded each STP, as we were then, with an amount of money ring fenced for general practice, and for Norfolk and Waveney that was around, I think, 4.5 million. Just looking at James on my screen for the nod, yes. And this year we haven't had any specific funding. What we have had is a recycling of funding that was already going to be due to the system for the primary care network impact and investment fund, and I think that equivalent is I'm looking at James again, around 700,000, maybe a bit less actually, and that was funding that was already mapped into the primary care networks. They just wouldn't have had it this early and wouldn't have been able to necessarily repurpose it. But as you can see, it's a small percentage of what they had before for winter, and as it stands, we don't expect to receive any general practice access funding like we did last winter.
Thanks, Sadie. James Granger, did you want to come in and add any more to that?
Other than that, agreeing with say, almost we're at the whim of non-recurrent funding here. So last year, that winter access funding was given non-recurrently, and that we were able to distribute that to practices and do some real good with that. Fortunately, that hasn't returned again this year, which is a shame. But we are where we are with in terms of the funding that we receive from NHS England to distribute out.
Thank you. All right. Well, thanks, colleagues, for the discussion there. I think the report was for noting, but I wonder, Mark, whether we should pick up as an action point something around the comms, actually. The system did really well last night on Look East, explaining itself around discharge and winter, didn't it? But I can just see how something on primary care, perhaps tracking it over a slightly longer report, might really help us get these points across to the public about the, as James Foster explained, the kind of sometimes unintended pressure that we're putting on our system and ourselves. So perhaps we'll pick that up as an action point if you're willing to think about it.
I think it'd be fantastic. Thank you, James. Yes, that's really good. Thank you.
Great. Okay, let's move on then, colleagues. And apologies if you're picking up any background noise. The learning disability nurses are having a party here in County Hall, which I can't begrudge them, but you might pick up a bit of that noise in the background. So should we move on then to the next item on our agenda, which is around the service development items now. So I think the first one is the learning disability health checks with Shepherd.
Thank you, James. A nice segue into the learning disabilities paper with that happening in the background. It's good to say that we are doing very well. We continue to do well with the annual health checks for people with learning disabilities. I will take the paper as read, but I just want to draw your attention to how we are doing as part of East of England, then just focus a little bit more on our system in terms of our ICS. Then the final part, I probably just want to draw your attention to a piece of work that our BI team has done to look at the rates of declines for the checks. So looking at the first part of it, which is how we are doing within the East of England, I think the table there clearly shows that we've seen more people than any other ICB in the region, followed by Herts and West Essex. We are clearly on target to meet our commitment for year end, both our local ambition as well as the national target, which is 75%. Looking at how we are doing as Norfolk and Waveney, just to say, I think we have maintained good progress across, but you can see, I think North Norfolk is slightly behind, but the position has not changed from last time. The activity seems to improve or increase in Q4. I'm sure we'll test that as we go through the discussions. Whilst obviously we are doing very well in terms of reaching out to many people, we are also paying high interest attention on how we improve the quality of annual health checks. And we had a positive meeting with colleagues from South and Mid Essex to discuss how they're doing their annual health checks and to get some learning from how they've improved. And we've got some work to take forward as part of from those discussions. In terms of risks, we are continuing to monitor the risks in terms of delivery risk. We know that we have done well for Q3, and now we are looking at Q4, where we expect more activity to be done. So we are closely monitoring that to make sure that we manage all potential drifts that may be associated with some of the pressures that we know this time of the year. Just to spend a little bit of time on the appendix, mainly because this committee did ask us to do some work around identifying those individuals that we have not been able to see. Our BI team has done some work to try and get to that. they've gone as far as identifying activity by practice, and they're not able to get to that level point where we can actually identify the individual that has not had an annual health check. But what is positive is that we are seeing more people than we have done before, which in essence, we are reaching out to possibly some of the people that we have not seen before. So if we look at the appendix, it tells us the number of people that have declined, and this data covers over an 18-month period. And I think what I just want to draw your attention to is just for you to notice the patterns in Q4. That is, if we look at January, February, March 22, I think it's just a confirmation and a reiteration of how we have organized our system in doing the annual health checks. We can see that if we look at March 22, we can see that about 190 people declined annual health checks. So the assumption is they were all offered and 190 declined. But if you go back into probably Q1, looking at May 21, you can see only one person declined. I think it's very clear that we spent more time in Q4. But as we move through, if I take you to the next, to the last part, which shows annual health checks being completed, that have been completed. And if we start from April 21, you can see the activity is much lower. If you zoom forward to April 22, you can see a significant change in the numbers, which just illustrates that we have started doing something different. You can see a nice pattern starting from April 22 going forward. The numbers are steady and it just shows how things are being managed. It's quite controlled performance. But if you look back from April 21, just going through that, you can see the numbers are a little bit erratic there. And looking at March 22, you've got about 953. So that shows that things were being left to the last minute, and that explains the number of declines. I think it's expected that people would decline because the pressure is just huge, and that would query the quality of annual health checks, in my view, if we look at last year. So I think the quality of our annual health checks will continue to improve as long as we demonstrate control and good management of activity. I will stop there and for any questions or any contributions from.
Thanks very much, Shepard, and thanks for explaining that mathematical point. I can see what you mean. The proportion of declines is a much lower proportion earlier in the year, as it were, compared with bunching it all up. Mel.
Yeah, just to come in on that point around declines, most practices would not record a decline on the first decline or on the first lack of contact being made. They would continue to try and deliver the health check over the course of the financial year, using opportunist methods as well as actual invitations, and it would only be till the very last opportunity that they would record a decline, because it would mean that they would stop inviting the patient. So I think that's why you'll be finding that your proportion of declines are all recorded towards the end of the year in most cases. So it's not necessarily that practices aren't calling them till the last quarter, it's the fact that the decline isn't recorded until the very last opportunity.
Right, I think I understand that, Mel. Thank you. That's really helpful to know. James, reader.
Yes, thank you very much indeed again. I think the figures speak very much for themselves, and the figure that really hit me was the 1,732 increase in the number of people who are now deemed to be registered. My question is, and this is because I'm completely non-clinical, why would a person decline? What are the main reasons for somebody declining? Thank you.
It's a really good question. Thanks, James. Shepard?
Absolutely, a very good question. So there are a number of reasons. I think what we've observed is there are different segments in our population that are not attending some checks. Predominantly those that are within the mild learning disability zone, and they are in employment. Some of them are holding some responsibilities in the community. So there are some adjustments that we need to do around that group of people. And also we've noticed also declines in younger people between the age of 14 and 15. So we are interested to look at how do we get around that. So we are really cutting the data to understand those behaviors or decisions that is associated with different groups. And also, I think the communication with people with learning disabilities seems to be one of the big factors, and this was reflected in the survey or the piece of work that was done by Open Doors. They carried out a review by contacting families and people with learning disabilities to find out how they would like to be contacted and to be communicated with. And clearly they wanted people to talk to them rather than writing letters. And our system is currently relying so much on writing to people. And within that, I'm not confident that reasonable adjustments are being done to be able to get those communication through. So there are loads of factors that are related to the declines. And I would even query and question the word decline, what that means. So we still have some work to do to really understand that those numbers in before we can come back and answer properly that question. Definitely a good question. Thank you.
Yeah, thanks, Shepard.
Could I-
Perhaps in the future.
Could I just come back on that?
Yeah, do, James.
okay?
Yeah, absolutely.
Yeah, certainly. If I can use my experience of children in care and with foster carers, our health checks are not where they should be, and that's because the difficulty of getting the children to the place where the assessment needs to be taken because of whether they're at school or the distance they've got to travel. So is provision being provided where the young or the person is with a learning disability, or are they expected to attend a particular clinic? Is that one of the barriers I put forward?
Possibly, but I think we are really fortunate in our region. We've got a lead for this area who is really, really interested in children and young in young people, and he's quite connected with schools and doing some fantastic work there. But I think access to surgeries, young people have got that, but we just need to test it. We just need to find out a bit more. Otherwise, I'll take it as a piece of work that we need to follow through and bring to this. Otherwise, I'll be answering in the general response.
Yeah. I was going to make that very point, Shepard, actually, that I know from my experience in social services that some of this is to do with providers and they're enabling people to get access into primary care as well as being accessible themselves to primary care. So there's something about the broader context, but perhaps if you will, you'll take a piece of an action from the report to give us a little bit more of a deep dive into the decline, since we've got some better information on it. Just a descriptive investigation as to what we think are the main causes and what we can do as a committee to promote overcoming those barriers. Okay, any other questions or comments on this? Otherwise, I'm conscious of time and I'll move the committee on if that's okay. Thank you very much, Shepard, for that. We are moving on to the companion report, are we, for mental health? And that's yourself again, Shepard, isn't it?
I've got my colleague Julian on the line.
Oh,
So
okay.
he will take us through that.
Sorry, Julian. I do beg your pardon. Julian.
Not a problem at all. Good afternoon, everyone. So I'm here to take you through the severe mental illness report for December, focusing using the data we have to hand, which is Q2 performance data. I think I'd like to separate my delivery on 3 main points. The first one will be looking at the performance, what the headlines are, and then the identification of risk moving into the winter months. So looking at the activity to date using our Q2 performance data, it is a success story. It's slow progress, but it is moving in the right direction. Norfolk and Waveney system carried out 37.5% more checks than we did in Q1, which was 283 more than we did the previous quarter. NSFT also contributed to that performance with 53 additional checks more in Q2 compared to the previous quarter. And when we combine both, we as a system have performed and undertaken 336 more checks in Q2 compared to Q1 for our patients with severe mental illness. I think putting that into the context of our local trajectory that we supply to NHSE, we have completed 3,924 checks out of a target of 3,948 for the quarter, which is 24 checks adrift of where we would like to be. It is under, but I think we are moving in the right upward direction. Our work with the charity Together, which helps to contact patients on behalf of practices that choose to opt in, is still ongoing. And we received some really good positive feedback from them. Just maintaining a link between the reasons for declines is another thing that I think for my own interest, I will take away and reach back to the charity Together. So they reach out to the more complex patients with SMI who traditionally are quite harder to engage with and do not resist is a wrong word, but do tend to stay away from engaging with these kind of services. So perhaps that's something I would look into just for my own learning. So that's in effect, that's where our performance lies. Moving into I think I might just skip over the headlines because I will leave that for last. But closely linked to performance is the identification of risk that the mental health commissioning team, along with us and the delegated team, would like to highlight to the members today, which is the potential risk to delivery during the winter seasons due to competing priorities. There's also the potential for staff absence due to sickness and annual leave. Looking at some of the performance through the previous years, Q4 tends to be, we tend to see a dip during the winter months from between January to about February. And then we see a bit of a catch up while practices come out of that winter pressure. But we have reached out to our locality colleagues and tried our best to put mitigation plans in place. But as I mentioned before, we do expect to see an upward trend in our performance in Q4, which is a catch up post the winter season. So just looking to our headlines, in terms of where we would like to be, we've got 2 pilots that we are still in the planning phase for, which I will provide an update to committee members at the next PCCC. There are some issues that I would like to iron out around recruitment, which I suspect might lead to a slippage in them. But one of them will be the Norwich pilot and the Swaffham and Downham pilots in the west, which both aim to use a dedicated pool of staff to deliver SMI checks solely. This is something that's new and it's not currently available in our systems. No extra monies will be required for these because the West pilot will be making use of existing staff that they've chosen to dedicate in a PCN to trial this out first, whereas the Norwich pilot is funded using ours monies. One of the main things for me, which I think will be able to translate some quick wins and low-hanging fruit, is the focus on the individual check. So if we look at the individual checks across the system, we average about 60% easy in terms of uptake. So that shows to me that there's a high number of patients going through our system. But when we look at all 6 as a whole, we average about 40%. So is there a coding issue here? Are we not targeting the right patients over here? Is it not focused? Is there a training gap in staff? I think that will be a lot of quick wins in our system. And finally, just on the headlines, we've collaborated with Suffolk, who've done a really good piece on data cleansing of their mental health registers. There are patients who could be on remission that are still shown as active on our register. So we've reached out to Suffolk to help us translate that into our system. Health check overall as a whole. I think there's a lot of quick wins in terms of translating, removing some of the barriers between the individual target areas. So when we look at the actual health check as a whole, learning disabilities, diabetes, and SMI, a lot of those checks that are being done are quite similar. BMI, smoking cessation, alcohol consumption. Can we remove those barriers? And if a patient is on multiple registers, could they go in as a one-stop shop for all of their checks? That's something that I think practices are already doing, speaking to our GP colleagues, but I think we can expand that further. And my last update is the location of the checks. I know it was mentioned in learning disabilities, but we would like to mimic some of the work done in London, whereby they reach out into the community, if appropriate, using a roadshow type of delivery. We have sustained interest from our community partners like Tesco and Slimming World to do one of these weekends with us for our patients, give them advice on healthy eating, etc. And if the environment is appropriate, potentially do the actual check. But I'm aware of time, so I'll stop there and happy to take any questions.
Yeah, thanks, Julian, for being so brief, but also really illuminating the numbers there, actually, to get a really good understanding of that. Any comments or questions from colleagues? It's clearly a complex challenge, this. Bill.
Yes, thank you for that. I'd be very keen to see some benchmarking, such as we have in the Learning Disability Health Checks report. And I think again that I pick up your point, Julian, about the learning from other. And I know the practices are very keen to tick off as many metrics with one visit as possible. So, I would applaud that. But I do think that in this whole area of health checks, which is going to be key to the prevention agenda, that's going to be one of the fundamental things underneath the new long-term plan, which is currently being written. Can we draw together some of the learning, especially because we had no movement or improvement in the learning disability health checks for years, and then suddenly we've now got a great team in, and we've seen a really positive change in an area that had been intractable for a long time. And I just wondered if we could leverage some of that into the others. Now, I'm not sure what other checks there are in the system, and would it be worth us doing a piece of work to look at the checks and to look at a way of systematizing this in a more efficient way for the practices and picking up all of them, or if they're a cohort of people who have to, I don't know, pick up medication or something, could we do it at a time that they are going to be doing that, so they might be more likely to interact with the practices? I think it might be a slightly bigger piece of work, but I'd be interested in us having a wider look at this issue. And at the moment I don't know what I don't know, so I don't know what the solutions to be, because I'm not fully aware of what the situation is. But I think this is an area that we're going to be more and more interested in going forward. I'd be keen for us to look at this a bit more closely, more generally.
If I could respond, Bill, very quickly. So I will take your point on benchmarking for the next report. I will take that on. In terms of the looking at it collaboratively across the annual health checks, I can confirm and very pleased to announce that that work is already commenced. So it's been 2 months in the working, and we've got clinical leads from learning disabilities, severe mental illness, diabetes, smoking, I think, is also there. And we're looking at the health checks as a whole. How can we translate those learnings across? We meet on a monthly basis. It's very much at the infancy stages, but perhaps for the next report, I can draw in some of our work so far into that report to give this committee oversight.
Great, thank you, Julian. That's really helpful. If you could, that'd be good. Thanks. Any other comments or questions, colleagues? Otherwise, thanks very much, Julian and Shepherd, for those two really crucial parts of our agenda. Let's move ourselves on then to the CQC reports. Now, Shepherd, we've got I think, a couple of reports on individual surgeries, and then we've got a sort of ratings overall report, haven't we? So to take them, they are for noting, take them as read. What would you like to draw out for the committee today?
Okay, we've got 2 practices that have been inspected, and you've got the reports with you. So I'll start with High Street, if it's okay. So this practice has been requires improvement for a while, and was recently inspected and has maintained that it requires improvement in that, and it requires improvement in 3 areas. That is the safe services, effectiveness, and responsiveness, and has been rated good in caring, which is really good to see that in terms of caring, people are still being cared for well, and has been rated as inadequate around the leadership aspect of it. Just to provide assurance that we have agreed an action plan with CQC, with the ICB, to help the practice to turn around, and there is a team that has been put together to support with the turnaround, and CQC are assured of what has been put in place. I'm confident that the practice will be able to turn around, and I'm sure I'll be able to illustrate that as I talk about the next practice, which members in here we reported, that is Manor Farm. So that practice was put in special measures about 6 to 8 months ago, and I'm really pleased to report that working together with colleagues, this practice has been turned around and has been inspected as good. So I'm confident that with the work and the learning that we have done with other practice, we'll be able to turn around this practice. So unless if my colleague Chris has got anything to add on to that, we'll move on to.
Any comments or questions, colleagues? Just for my benefit, Shepherd, though, did you say the Lowestoft surgery had been RI for quite some time? I just wondered about the stickiness of that score. But James, did you want to come in? You're asking a proper question. Why don't you ask that first, and then we'll go back to Shepherd.
Thank you very much, James. That's very kind. No, I think very much the question was what you were asking. It's really encouraging to see a practice going from inadequate to, I think it was good, wasn't it, in one step, which is quite remarkable. And therefore, as Shepherd, as you've said, there are systems that can help practices. My question was, why has this high street been since 2015? Have they not been offered help? Has that help been accepted? Or why is the reason that one other practice could have got help and moved so dramatically, whereas this other one from 2015 hasn't? And if I could just make one point, and I don't know if others, and particularly Andrew from Health Watch, I have a real problem with some of our inspections that they are damaging rather than helping the system improve. And I don't know how we influence the powers to be to ensure that inspections are part of the process to make service delivery better, rather than perhaps destroying services because of I'm struggling my words because I'm being very, very careful, that do not, if you've got a practice or anything that has got a bad rating, then trying to attract staff is very, very difficult, and consequently getting out of it is very hard. So I don't know if there's anything we can do to influence that. Thanks.
Yeah, thanks, James. That's really, really clear, very helpful. With your permission, Shepherd, I'll take Christopher's question and then come back to you, Chris.
Thanks, James. So yeah, just to try and answer the first part of that in terms of the variation between practices. I think we take a very similar approach between Shepherd, my team, and others in the ICB. We try and support practices in the same way by offering to go in and offer our support. And I think it's fair to say some practices are more receptive to that than others, and to the degree of help that they will accept and let us support. And I know with Manor Farm in particular, you know, we did manage to get in there. We did do some work with them prior to their re-inspection. I think that's probably paid dividends in terms of how they've improved. But sometimes, whilst we offer the help, sometimes practices will say to us, we know what we're doing and we have to, all we can do is offer. We can't impose it on practices, I guess is what I'm trying to say.
Yeah, understood. Thanks, Chris. Bill?
Thank you. Just on that last point, then, do we do a set or some sort of communication to demonstrate what can happen if a practice accepts our help? So sort of PR around the help you could get to try and reduce practices saying that they don't want our help. I mean, I think some case studies of where you've had a dramatic turnaround, and all of that means for morale in the staff and recruitment and all of the other stuff. You know, I find it very difficult that if that positive story is being properly shared, why, you know, and I accept that practices are independent and they're run by particular characters and stuff, but I just think would that, are we doing that, and if we did, do we think that that might reduce the take up or the lack of take up for support?
Yeah, thanks. Chris, do you want to come back?
Yeah, thank you. Thanks, Bill. So that's a good point. So we've recently, it's been going for several months now, but we have a monthly bite-size kind of CQC session. So focusing on some of the key things that CQC may pick up as part of their inspection. So through that, we may share if something's worked particularly well at a practice or a specific tool that they might use for certain things. So we certainly pick up that type of thing through those forums, and there is a suite of different tools and supportive documents that we do share with practices as well. But that's not to say that we can, I'm sure that's something Shepherd and I can look at in terms of really pushing that message. I think that's quite a good idea.
Thanks, Chris. Thank you. And Andrew?
Yeah, I just wanted to chip in and say, first of all, to acknowledge that the vast majority of our practice is either good or outstanding. That needs saying probably. And just for everybody to remember, the CQC is a regulator. So it comments on regulations and where regulations are broken. And it's not really a very good arbiter of clinical standards. So you can have the rather odd happening where individual clinicians in a practice are doing a very good job, but the CQC provides a low rating because of not meeting regulations, which are often managerial rather than clinical. And I wonder if there's any pattern in the sense of staff to patient ratios to look at, and also, most importantly, staff stability, because if you get a big churn of clinical staff, whether that has an impact and whether that's the pattern to look at.
Yeah, thank you, Andrew. And that sort of conversation is now broadening us out, really, isn't it, from these two? So I think we understand the two into the other report, which tells us, you know, 87.6 or whatever it was is good or outstanding, as it were. So do you want to? Who wants to come in on that? Shepherd. Oh, sorry, Bill, is your hand up again? Beg your pardon.
Sorry, I will be quiet in a minute. I just wanted to say we had talked about other indicators, for example, like prescribing levels and people that used, you know, the Tofolonit. I just wonder if are we using as a committee or a system the other indicators that haven't been previously mapped, to see, to give us a clearer picture, as Andrew rightly says, that goes beyond the sort of pure regulation of the CQC.
Okay.
Shepard, do you want to pick all those points
Yeah,
up?
if I pick on this and move on to the next, if you are in agreement, because I think the next report could also allow those conversations. Just to draw a distinction between the two practices, because I can see that the conversation is not comparing the like for like. So Manor Farm was in special measures. High Street requires improvement. So the interventions for requires improvement are not quite the same as for somebody who is in special measures. But for for High Street, we have upped the interventions to support them more with enhanced support, because they have been requires improvement for a long time. So that brings the distinction why, and it probably answers James' point, why is it one practice has been moved from inadequate to good? It's because of the level of package that has been put following the inspection levels. But I think there's a learning there for us in terms of what we need to do again with practices that requires improvements.
Yeah. Do you want to move us on then, Shepard, to the broader
absolutely.
report?
Absolutely. Trying to find that report. Oh dear. Okay. So in the next report, this is really to provide the committee with an overview of the CQC activity and also the ratings that for our practice across the region. So I think there are two parts that I will focus on. That is, the first one is the current status in terms of the ratings. So clearly in that table, you've got 4 practices that are sitting in the inadequate zone. But just to say that that area has got movement. So it could be at the point of writing, potentially there were 4, but I would not be surprised that with some of the inspections, potentially that number has reduced. I'm expecting that area to be completely zero at some point in the next 6 months if it goes per plan. And just to assure you that there's a lot of support to turn around those practices. So we should see a change from there. And already we've seen some practices moving from inadequate to requires improvement. And I think it's one practice in Norwich that has moved from there. So the numbers are expected to change within those spaces. And just to echo Andrew's point, that is literally between the inadequate and requires improvement. We're talking about probably about 6% of the practices across our patch. It's good to see that we are good with most of our practices. But I know that some of the practices have not been inspected over a long time. So we should expect some changes in that. But to manage that, we are proactively trying to work with colleagues to identify with soft intelligence practices that potentially could not do well when inspected. And the practice visits program, we are hoping to kickstart that quite soon with additional resources that has been agreed. So that is that on that table. The next table is really about the inspection activity over the last 7 years. I'm not going to comment about 2015 because that draws quite a lot of attention to actually say what was happening, 3 inspections in that period. But I'll probably draw your attention to the level of activity from 2016 to 2018. You can see increased activity during that period, then the reduction in activity as you follow through to the following years. And we are starting to see the activity go up. And with that, we expect potentially more practice to start being challenged with the new inspection approaches that we are seeing, especially, I think, the medicines management in terms of the comparative approaches around prescribing for antipsychotics, antibiotics, painkillers, and anxiolytics. I think a number of our practices will probably fall short in that. But I suppose that triggers a conversation that we need to have as a system so that we can help the practices not to fall, or practice and CQC to make sense of this in terms of how we would handle that. We are aware we've got all the information that we need in terms of what are the areas all our practices are challenged. That is around the governance, that is around leadership. So we are proactively working through that, through the bite sizes that Chris has spoken about. So there's a lot going on. So we expect that we will respond to the required improvements and also the inspections that are needed. I will stop there around that.
Thanks, Shepard. Yeah, thanks, Shepard. It's clearly complex, isn't it? And I can see you're an optimist at one level, because I guess the fact that CQC haven't inspected for quite a long time and seem to be struggling with the capacity a bit it could be that there's lots of goods and outstanding out there that they haven't discovered, or it could be given the pressures that we might be pushed more towards RI, I suppose, which is happening in a lot of public services. But I guess you're saying the program, the practice visits, the program of quality assurance, as it were, might help you anticipate that and put the support in early so that that doesn't happen, is what I'm sort of taking from what you've described. Are there any comments or questions from the committee about the detail of that? I think it's a really clear report, by the way. Any observations that people want to make? No, anything else you want to add, Shepard?
Just to confirm that our CQC colleagues really care about our practices, and I think we need to encourage practices to reach out, because they are willing to have conversations, and I don't know how we do that, but genuinely they do care about practices doing well.
Yeah, of course. Yeah, be good to. I'm presuming that as part of the ICB, Mark, the relationship with CQC is sort of strategic as well as regulatory in that sense. So obviously you can't interfere with the regulatory task, but actually we would want to have a regional and local relationship with them so that their knowledge about how we do improvement and improvement support gets transferred to us, as it were. Mark.
Yes, James, absolutely, and it's that kind of formal and informal conversation and network that we have with the CQC colleagues is very helpful, actually, at a strategic and local level. So yeah, completely, and I think it's something that we should build upon, because an early conversation is better than a coming in and you know, assessment and regulation. So absolutely.
Yeah, great. Okay, thank you. All right, we'll move on then, if that's okay, then to the finance and governance part of the meeting.
James, sorry, I had my hand up. That's okay.
I beg your pardon, I
no,
didn't spot
that's
that.
okay. I just wanted to reiterate Mark's comments that the LMC also has that relationship with CQC, and Naomi Woodhouse leads for us on that and does meet with CQC regularly along with the ICB. It's just how we pull that three-way conversation together, perhaps a bit more thoroughly and a bit earlier, I think would probably be helpful. But yeah, just to reiterate those comments that we also have that relationship with CQC.
Sure, thank you, Mel. Sorry for missing your hand. Okay, so move on to finance and governance then. So the first one is the prescribing report, and again this is for noting for the committee. And is this trying to remember the name? Jessica, isn't it? Yes. You look poised, Jessica. Go ahead.
I am here. Hello, everybody. For those who don't know me, I'm Jessica Adcock, and I'm the head of Pharmacy Meds Optimisation at the ICB. So the report is as presented. There's a few highlights that I'd like to bring up. So we are looking at our PQS indicators for next year, 23-24, and they are being developed at the moment. Our greener inhaler initiative is producing the desired effect, and the data is showing between April and September we have reduced the carbon output from inhalers by 500 tonnes. We've launched our opioid reduction toolkit last month, and that was well attended, and we're continuing to offer support to practices with other tools to help support the deprescribing. One request from the committee last month for antimicrobial stewardship was an East of England picture. So table 7 is illustrating that. And I'd like the committee to note in antimicrobial stewardship that the Swaffinham Down and PCN continuing on a downward trend of prescribing of total antimicrobials, and they've reduced for the 3rd month in a row, and they are now in the middle target. So it's a fantastic achievement to see. Any questions?
You're muted, James.
Oh, sorry, chair's error. I beg your pardon. I was just praising your description there, Jessica, and the clarity again of the report. But any comments or questions from members of the committee? James, reader.
I was fascinated. Thank you. I was fascinated by that statistic of a reduction of 500 tons of carbon from the sorry,
the greener inhalers.
The inhalers. Can you very briefly just say however that happens? How that's possible?
How that happens? Yes. So we've been working with our practices when they're reviewing patients annually for their inhaler treatment for either asthma or COPD, that they review the device being used at that time. And we now have a list of preferred greener options, which are the ones that don't contain aerosols. And so this is the outcome of that work that's been happening across our practices.
Excellent. Thank you.
Thank you. Thanks, Jessica. And Hein.
Thank you, Jessica. Table 9, which is on page 52, shows outlier practices. I was just wondering, are you satisfied with the traction you have in getting attention from those practices and open for tools, etc.?
Yeah, so I've met with the regional antimicrobial pharmacist last month at our antimicrobial stewardship working group, and as a group we discussed why is improvement not happening in these places. So the agreement that we've decided to target is we're going to look at the highest prescriber in each of the top 4 PCNs, so we can look for trends happening in those practices, and then we can then use that learning to work with other practices as well.
Okay, thank you.
Thank you.
Thanks, Hein. Thanks, Jessica. Andrew?
Yeah, can I just ask quickly? There's a lot of discussion at the moment about lowering of thresholds for antibiotic prescribing in reaction to all the strep A concerns. And firstly, obviously, that will make a difference to the future statistics, which I'm sure you've got at hand. But secondly, do you know of the supply situation locally? Because we're assured nationally, and I'm sure it's true, that there's no shortage, but it's the distribution that is the problem. So there's locally occurring shortages. Are you aware of any particular problems locally with that?
So we're monitoring it daily. We're working with our community pharmacy leads and with the hospital trust pharmacies. There is a shortage. We're very aware of that. We are, as national guidance says, we're asking that our GP practices are communicating with their local pharmacies regularly to find out what is available and to work together to give the most appropriate antibiotic that is available at that time. We have an agreement with the trust that if the supply becomes worse, that we will have a process ready in place to be able to divert patients to the hospital stocks as well. But it is out of our hand to be able to magically produce these supplies of antibiotics that just aren't there at the moment.
Are we still with the situation where the formulation has to be as prescribed? So,
unfortunately, we are. Yes, there's been no short stock protocol issued, which is disappointing because that relieves the pressure on the practice who are actually prescribing it, allows the pharmacist to give what is available at the time, which is why we are having to say, make sure you're communicating locally. I was speaking to some colleagues yesterday and they said that they had communicated to their local practices that the tablets they had, and they are educating patients, parents to be able to crush the preparation and able to administer it to the child.
Yeah, great. Thank you.
Yeah, thank you.
Thank you, Andrew. Thanks, Jessica. Okay, are the committee happy then to note the progress on this? Oh, Bill.
Just to say, this was something that came up at the integrated care partnership when they were looking at the joint pharmaceutical needs assessment. Even though the overall assessment was that the range of pharmacies was suitable, there was a lot of anecdotal evidence given to the committee to say that there were shortages, and it wasn't always of the medicines, but often of staff in the pharmacists as well as part of the workforce. So that's why things weren't available or processed, because the pharmacists were shut because there wasn't enough staff. So it has been highlighted at a system level through the ICP, and so this isn't the only report that's highlighting these issues.
Yeah, thank you, Bill. Definitely bigger picture. And I suppose acknowledgement of the ICB, actually, Mark, that there is more to do on pharmacy more generally, and it's sort of coming, it's coming this way, isn't it? I think is that a fair summary? I suppose
it certainly is. With that and dentistry, it'll keep us busy for a while,
yeah.
I'm sure.
Yeah, great. Okay, thank you very much. Okay, thank you, Jessica. So we'll move on then, if that's okay. Your hand's still up, Andrew, but I presume that's a legacy from before. So the next item on our agenda, I think, is our finance report. And we've got James with us. James, are you leading us through this? You've got some slides as well, haven't you? So yeah, take it as read.
Yeah, I'll take the report to maybe highlight some of the key points in there to the committee. So the report is produced in arrears due to the timing of the ICB month end. So it's reporting the 4th month of the ICB accounts, which is month 7 of the financial year, and has a forecast of 9 months for the ICB. Looking at the exec summary, you can see the position at month 7 for primary care and prescribing budgets are £2.2 million favourable to budget for the ICB, which represents Q2 to Q4 of the financial year. This position includes an efficiency target of just over £7.3 million built into the budget, and this forms part of the full year efficiency requirement of £8.4 million. As you can see, these efficiencies are not phased in a linear fashion and do build up over the year, but through continued monitoring of the efficiency projects, we are at month 7 still forecasting them to deliver on plan. However, there are potentially some slippage to be forecast from month 8 onwards. The risk around DOAC switching, which I reported last month, is now reduced and looks more on plan, and then the major area of slippage is now with the low risk cost effective switching project. Moving on to the financial summary page, this shows that GP prescribing is 0.3 adverse to plan at month 7, with the figures being 2 months in arrears. This is showing the April to August estimates cumulatively were marginally undervalued. In addition, efficiency savings have materialised in the period allowing the forecast to be delivered, and these efficiency expectations are already baked into the budget. Of the £7.3 million requirement for the 9 months, we've received 5 months of actual achievement, and this to date has over-delivered. However, the budget phasing of these efficiencies does increase rapidly from this point onwards, and the delivery will need to match that for us to be on plan. There are also some prior year benefits within GP prescribing contributing to that positive variance. There's also a prior year benefit and other positive variants within delegated primary care, which have crystallised worth £1.6 million year to date, which I'll cover a bit later. Moving on to the detailed financial analysis page, this shows the key drivers behind the prescribing spend being on plan. However, there are still some key areas of risk around continuous glucose monitoring and SGLT2, as previously reported. There's a high degree of uncertainty over the financial implications of these factors. We receive additional EPAC figures for DOAC, CGM and SGLT2, which allow us to monitor the year-on-year increases in these areas, and they are all at the moment showing large year-on-year increases as at month 7. Moving on to specific funding areas for the System Development Fund, this key area of investment is showing it as on plan still, and is closely scrutinised both locally and nationally through the financial returns to NHS England. Moving on to delegated co-commissioning, the underspend here is predominantly due to the way in which PMS GMS budgets are ring-fenced to delegated primary care, and also the primary care, the prior year credits that I talked about previously, which are most specifically around the accruals from QOF at the end of 21-22. And then finally, the last area, GP and other prescribing. This slide shows the detailed variances with prescribing leading to the overall 9-month adverse forecast of 0.7 million. As you can see, this has moved quite significantly from month 6 to month 7, as some of these prescribing pressures that we're talking about have started to materialise. It still needs to be reported there's a large degree of uncertainty and risk within prescribing, but the finance and meds management teams work closely together to monitor the EPAC data and the key areas of risk around DOACs, CGM and SGLT2. And as I said previously, we can see that the year-on-year comparison, these areas are growing quite considerably, more so than the growth that's been built into our budget. Other area of risk, a high degree of pressure coming from NCSO or no cheaper stock obtainable items. We've seen some really high increases in prices, which will begin to materialise probably in month 8 and look to stabilise in sort of month 9 to month 10. And that was what I was going to go through. So are there any questions?
Thanks very much, James. Complex budget, that, isn't it?
Right, so.
Yeah, but on track so far, but with real rising pressures, I suppose, is what you're saying. Some decision based and some cost based.
I think that's the key message. Absolutely, yeah.
Okay. Any comments or questions in that area from the committee? Otherwise, we will note that. So we note that, James. I'm sorry if you wanted a more of a conversation about it, but you probably not actually. Okay, good. All right. Well, thank you, colleagues. So we're now into any other business, and the standard item there is item 12, questions from the public. So Sadie or Sarah, do we have any questions from the public that have been submitted?
Not from me, thank you.
Okay, great. All right. So I think that's the closure of the part 1 of the meeting. Would the committee like a 10-minute break before part 2? Should we come back at I don't know, 3:10? Is that all right? That's 15 minutes actually. Is that okay? 15-minute break, 3:10, and we'll see you for part 2. Thanks very much, colleagues.